My mother graduated law school when she was 40 years old. She never wanted to be an attorney, but the business that she ran with my stepfather needed to have an attorney, and somehow she was chosen to go to law school, pass the bar, and practice to serve the business. Now, I can imagine since the early 1970s, when she was a single mother with 3 children, she did a lot of things that she would have not foreseen for herself. Just like you and I have done things as we raise a family and grow professionally that maybe weren't in our vision for our life. And retirement is one of those times when you can grasp an opportunity to live a life a little bit more true to yourself. And we're going to talk about that today. And we're also going to talk with Danielle Roberts from Boomer Benefits as we continue this month-long series on Medicare and making a wise Medicare decision. We're going to dive into Part D. In addition, we're going to answer some of your questions, all today on the Retirement Answer Man Show. Welcome to the show. I'm your host, Roger Whitney. I'm so excited that you're here. Let's not waste any time. Let's get started with the What's That Mean segment and talk a little bit about regret and how we could use it to our advantage.
Huh? What does that mean?
Regret is defined as feel sad, repentant, or disappointed over something that has happened or a loss or missed opportunity. My guess is my mom had some regrets when she passed away at age 48. Not getting to this stage of retirement where you get to recreate yourself. I know that she looked forward to retirement as sort of her time in life to really live her life, having sacrificed so much to raise myself and my 2 sisters. So you are here near retirement, where you're going to shed a lot of the obligations and roles that you've played. Now is your chance. Now is your chance to really create a life that is an expression of who you are and what you want to stand for. The top regret of those on their deathbed, by a mile, is, I wish I'd had the courage to live a life true to myself and not the life others expected of me. And retirement for a lot of us is that moment in time when we can embrace and lean into that to minimize the possibility of regret. This can sound all sort of sad, but it's not. I look at my mother's journey and it drives me to do the things that I do and to try to live a life true to myself. So this is your opportunity to really imagine it. So the question is, what are you going to do with it? So here's part 2 of our discussion on Medicare. We're going to continue to build out a framework so you have a really good understanding of Medicare and how it works. And we're going to give you a resource each week to help you build some knowledge so when you get to this point in life, you can make a great decision. So this week, we're going to be talking about Medicare Part D, and we have a free resource for you provided by Danielle Roberts of Boomer Benefits. And you can get that in our 6-Shot Saturday email, which is our weekly email that goes out to listeners of the show. And you can sign up for that if you're not already at rogerwhitney.com. Right there on the front page, you can put in your name and email, and we'll send you 1 email a week. And this Saturday, we'll be sharing a resource on helping you understand Medicare Part D. With that, let's continue our discussion with Danielle Roberts from Boomer Benefits. So we're back, and we're going to address Part D and what Medicare doesn't cover with Danielle Roberts from Boomer Benefits. Hey, Danielle, do you realize, I'm sure you do, it's 2 weeks and 1 day until the page turner on Medicare that you wrote comes out.
Isn't that the most exciting thing you've ever heard? A whole book about Medicare.
Yes. I heard you already sold the movie script, the movie rights.
Yeah, that's right. Brad Pitt's starring in that for me.
We're excited about it, and we'll definitely have links to it because you know your stuff and you communicate. What I like, I think, Danielle, not just about you, but your whole team, is that you communicate in human speech, right, as a person, and it really helps a lot. So today we're going to talk about Part D and what Medicare doesn't cover. So last week was Part A and Part B. Part D is the drug benefit, and it's fairly new, correct? So give me the lowdown on Part D.
It was rolled out in 2006. And the reason that we didn't have any drug coverage before that was, again, back in the day, in the 60s, these were not things that were typically covered by the kind of insurance that was there. So can you imagine, for over 40 years, beneficiaries would have drug coverage their whole life and then suddenly go on to a national health insurance program that didn't pay anything for their medications. Unless they were getting them in a hospital, you could go from spending a few copays at your employer to hundreds or thousands of dollars paying out of pocket for medicines on Medicare. So there was quite a clamor about this for many decades. And finally, Medicare created an optional, a voluntary program, Medicare Part D, that people could enroll in beginning in 2006 that would help them with the cost of their medications.
That is pretty amazing if you think about it, that it wasn't covered under Medicare for a very long time. And I imagine part of that is people take a lot more medications than they used to, and they're much more sophisticated medications that really get dialed in, which means they're a lot more expensive. So it makes sense.
Yeah, you're right. The research and development and the growth of the pharmaceutical manufacturers means we have literally thousands more medications for things today than we did back then. And so it became necessary. Some medicines, diabetes medicines, and they're under patent, can be $600 a month. And so that is not something that would have been that kind of expense for someone back in the day. And there was really a great need to help people because this is also the time of life when you're moving from having an income to living off of savings, a fixed income, a little bit of Social Security. So a $600 medication can be devastating for someone at that stage.
And as a reminder, we're going to talk about your Medicare decision in the last episode in the series, where we'll get into the costs. Like Part A is free, Part B costs money, Part D costs money. But I thought we'd divide it up a little bit differently than we talk about it, so we really get into the coverage. So Part D covers drugs. Give me the basics of how it operates from a coverage standpoint.
Okay. So Part D, it's called a voluntary program, but you should know that if you don't sign up when you're first eligible and you don't have any other creditable drug coverage, like through an employer where you're still working, and later on down the road you do decide to enroll, they will penalize you for not enrolling. And this is because, of course, they need individuals who are healthy to be paying into the Part D system to make it affordable for everyone else. And Part D plans have evolved a lot since they first were rolled out in 2006. But all Part D drug plans have 4 stages. The first stage, just like with Part A and Part B, is a deductible. And Medicare itself sets the deductible each year. And insurance companies who offer Part D plans can either build that deductible into their plan, or they can charge you less, or they can waive that deductible. So just to sum that up, you enroll in A and B at the Social Security office, but Medicare Part D drug plans, there's dozens of them in every state, and each insurance company that offers one, Medicare tracks that enrollment, but the coverage is through a private insurance company who decides whether or not they will use Medicare's deductible or charge a lesser deductible. This year, in 2020, the deductible is almost $450. So that's quite a big chunk of change that you would spend on drugs out of pocket before the coverage kicks in. And you're going to be evaluating each plan to say, what's the premium on this plan? What's the deductible? Would I rather have a plan with a higher premium and pay a lower deductible? Or do I want to go ahead and have that deductible up front and have a lower premium and maybe some lower copays on my drugs thereafter?
So essentially, I'm going to restate that for clarity for myself and hopefully so with Part D, what you have is the government said, we don't want to operate this like Part A, Part B. So we're going to set the framework and the guidelines and let private companies operate within those guidelines.
Absolutely.
Right? So in terms of how they execute the plan. But the private companies, say Company A, and well, we better not use that, Company 1 and Company 2, can choose how they operate in those guidelines. So Company 1 could say, I'm going to charge $50 a month, but you're going to have the full $450 deductible. And Company 2 can say, I'm going to charge $70 a month, and you're not going to have any deductible. But as long as it's within the guidelines. So when you're trying to compare apples to apples, they really end up being apples to apples if you're using all of the coverage. But if you don't use a lot of drugs, you may go with the one that gets to the 450. Is that?
Yeah, that's right. I like to tell our clients here, they're usually going to get the 450 out of you one way or the other. They're going to get it in either higher premiums or higher drug copays. So you end up paying that. But if you are someone that takes little to no medications, then you may not want to spend a lot of money on a drug plan, and you will have opportunities to change your plan down the road. So we might advise that you go with the least expensive plan in your state. In most states, there's plans that start around $15 a month. So you would have some coverage in an emergency. You might have a deductible higher than what you want, but at least the coverage is there. So if mid-year you get sick, you're not going to have no coverage at all and have to wait until the next election period when you could get a Part D drug plan.
Okay. So it's very similar to I choose a higher deductible on my home insurance, so my premium's lower. Okay.
Yes.
Okay. So, and I'm assuming you get a card, a drug prescription card, and then it processes probably like normal insurance processes. You have a copay.
Yeah. So you'll have a card that you show at the pharmacy. The pharmacist will run that. He'll see if you've got a deductible or not that he's got to have you pay into. Let's say you do have a $400 deductible on your plan. If you fill a medication that's $100, now the next time you fill another drug, you'll owe $300, and until you'll chip away at that until the deductible is satisfied. Once the deductible has been satisfied, then you'll move into stage 2 of your drug plan, which is called initial coverage. And this is where the pharmacist will say, oh, this medicine is in the tier 3, which is a preferred brand, and your copay for that medicine on your plan is $40, $50, whatever the plan has set. So once you've paid the deductible, that card is going to tell your pharmacist what copay he needs to collect from you at the pharmacy before he sends off his bill to Part D to pay the rest of that drug. And all Part D drug plans typically have 5 tiers of medications. And just like on other plans you've had in the past, the tier 1 preferred generic drugs are going to be the cheapest, then non-preferred generics, preferred brands, non-preferred brands, and specialty medications. So the higher the tier, typically the more your share of the medication will be.
So are those tiers? So we got the cheap drugs to the designer drugs in this case. Are those tiers and copays level through different kind of providers, or does each provider get to say, well, that's a tier 1, but another one will say that's a tier 2?
It is the same tier no matter where you fill it, but plans often have preferred pharmacies that you can use. And when you go to that pharmacy, you'll have a lesser copay. A lot of times they'll give you lesser copays for mail order. If you go to a non-preferred pharmacy, you'll pay more for that drug, even though it's in the same tier in most cases.
Okay. So you want to be aware of that as you're choosing your plan and what drugs you potentially use, because if the preferred pharmacy is 40 miles away and you got a CVS right down the corner, it sounds like it's simple, but it's not when you have to go get it.
That's right. And when you use your mymedicare.gov portal, also allows you access to Medicare's Plan Finder tool. So we talked about that portal in the last episode. You can go into that portal and run a list of medications, and you can sort them, and you can see all the companies offering plans in your area, and it will actually let you choose your top 2 or 3 pharmacies. So if you love to go to CVS or Walgreens, you can set that to sort so that you're shown the plans that give you the best prices for that pharmacy. And that sometimes can be something to look at, because maybe another pharmacy 5 miles away has better pricing. You would then be deciding, okay, which route do I want to go with my drug plan?
Yeah, and some drugs are what they call it, formulary, where they actually have to be made, not just putting pills in a bottle. I imagine that's a consideration too. I know my wife had a few that you had to go to a specialty pharmacy, and you have to figure out how to navigate that, I guess.
Yeah, with Part D, typically they're going to have, each company is going to set its own formulary list of medications that are covered. But if you have a medication that's compounded, often that is not one that Medicare Part D will cover, because there's not a way for them to assess usually which tier that would have gone into. So fortunately, a lot of those compound medications aren't too expensive. But again, it will be something else you want to consider. You're going to want to check with that compounding pharmacy what it's going to cost you to pay cash for that drug so that you're prepared for that going in.
Do people typically take Part D? Is that pretty much a normal thing everybody's doing?
Yeah, around 70% of beneficiaries will enroll in a Part D drug program. And the other 30% may be people that have another option for Part D. Perhaps you're a veteran and you intend to get all your medicines through the VA, or you're still working, or you have Indian tribal part drug benefits. Those people may or may not want to enroll in Part D, but most people do. And we recommend it, of course, because we've seen the instances where people don't have one and then do end up with a very expensive medication. There are a lot of cancer medications these days that are oral chemo medications, and they are literally thousands of dollars a month. So Part D has 2 other stages that we'll get into here But the last one is catastrophic coverage. And you want to have that cap on spending, your out-of-pocket drug spending, so that if you do end up in a worst case scenario with a really expensive medication for a life-threatening condition, you have something to sort of help you stem the bleeding at some point on your finances.
Well, let's go to my client that had the heart transplant. I imagine there's some pretty serious medications he's got to take for the rest of his life.
Yeah.
So what is our exposure from a cost standpoint using Part D, from obviously the minimal deductible, but going all the way up?
So in 2020, you would hit the catastrophic coverage level at around $6,350. And that would be money that you have spent out of pocket, as well as some of the discounts that the manufacturers give you in stage 3, which is the coverage gap. So it might not have been the whole $6,350 out of your pocket, but it's going to be close. So it's quite a pretty penny that you could spend. But then when you hit that catastrophic coverage limit, after that, the insurance companies have to cover 95% of the cost of your drugs for the rest of the year. So you will find that you may spend only a few dollars for medications after that point. But if you had a really expensive drug that was a $5,000 drug, you might still be spending a couple $100 a month at the 5% level. It's very important to have that so that you don't have runaway costs on a life-threatening medication. But you need to know that going into Part D, hey, $6,300 is still a chunk of change. And you want to be prepared for that. You want to have some money set aside for a rainy day. If you have a year where you have some pretty expensive medications, it's going to help you a lot if you've got some money stashed away in an HSA or account that you leave just for medical spending in the future.
So did they do away with the donut?
There is still a donut hole, but it works differently. Would you like me to walk you through that?
Why not? Why not? This is the worst kind of donut. There's no delicious flavor to this at all.
That's right. It is the Roundup flavored donut. It's just gross.
A dirt donut.
Yes, it's a dirty donut. So in 2006, when the drug plans were rolled out, Congress had to come up with a way to get the cooperation of Medicare beneficiaries in using generic drugs, which are lower cost, so that we could keep the cost of the Part D program down as a whole. If you think about it, it makes sense. If your doctor can always prescribe a brand name drug and you always fill the brand name drug, the nation's going to pay a lot more for Part D than if your doctor will prescribe a generic and you ask for a generic. So what they did was they created this big hole in the middle of the plan where if your drug spending went over a certain dollar amount each year, you then would pay 100% of the cost of your drugs when you were in that donut hole. So you would be very likely to ask your doctor for a generic because you're trying to limit the number of dollars that are being added up each year toward your cost of medications to keep out of that part of the year where you have to fork over 100% of the cost of your medications. That has changed due to the Affordable Care Act. That donut hole percentage has slowly come down. And now in 2020 and beyond, you will pay 25% of the cost of your medications in the gap. So you still have the Part D plan paying the majority of the cost, but you might find that your medication gets higher from stage 2 to stage 3 because maybe in stage 2, you just had a copay, but in stage 3, now they're going to charge you the full 25%. If you've got a drug that's a few $100s, you may go from paying a $30 or $40 copay to a $100 copay when you're in the gap. So it does still exist. It's just not quite as painful as it was in the original version of Part D.
I did not realize that the objective there was to incentivize generics.
Absolutely. They need that cooperation from you because otherwise the doctors aren't going to care. They want to prescribe you whatever the pharmaceutical rep is pushing when they meet with them in their office. They need you to be asking for those generics.
And the drugs that we see marketed are the name brand, the Gucci of drugs, not the generic version of the drug. And the branding of the names of a drug is really important nowadays.
Mm-hmm.
So interesting. Okay. So buy generic. Same thing. When we're talking about the discounts with drugs, I know a lot of drug companies have programs to assist in covering the cost of a drug. In pre-Medicare, some of these drugs like Humira, which is one we're all familiar with, it's $5,000, $6,000 a month, but they actually have people that will go around and help you figure out how to pay for it and actually assist you in the out-of-pocket part. Are those systems in place with those drug companies in Medicare Part D?
There are still pharmaceutical programs through drug companies and the state, but a lot of times you would be disqualified for having Medicare Part D. So it's something to consider because if the Part D is going to charge you X dollars for this, and you can get this one really expensive medication a lot cheaper through a pharmaceutical program, that might be a reason why you don't enroll in Part D. But the tricky part is then you don't have coverage for all those other medications that you might be taking. So it's good to always do your research on that upfront. There are some manufacturers that will work with Part D patients, but on the average, most of them won't once you have coverage.
And if you choose to go that route of foregoing Part D, which you'll likely will do, if you choose to decide to pivot back to Part D, you're going to be penalized from a premium standpoint for not participating.
Yeah, that's right.
Okay, so that's something you need to be aware of. What doesn't Medicare cover? Where are the gaps in Medicare Part A, B, and then we can throw in D if we want? Because that's the basic Medicare, what we just talked about, right? Last week and this week. So where are the gaps?
So Medicare doesn't cover routine dental, vision, and hearing. So if you have something wrong with your eye, like glaucoma, they're going to cover that. But they aren't going to cover that optometrist visit that you have once a year just to get your new prescription. That's typically not covered. So you would be now paying for your own eye exam for that and your own eyeglasses going forward. It doesn't cover routine dental. So this is something we've grown very used to having covered by our employers. You can purchase private plans on the individual market through brokers like us, or just by going to Google and typing in senior individual dental plan, and you can see a whole host of different options for that, or you can pay cash for your dental needs. Hearing is a big one. A lot of people are very surprised to find out that hearing isn't covered. But if you think about it, back in the 60s, our life expectancy wasn't the same. And so hearing coverage wasn't quite what it is today, because Americans are living so much longer now, and you have more years to lose your hearing. So
what? Yes, I'm sorry, that's silly. Go ahead.
Maybe you need some help with that, but it's something that is quite an expense. So you would need to be prepared for paying your own hearing aids.
And that's life-changing, by the way.
Of course.
I know people that have gotten hearing aids, and it changes their life in a lot of ways.
Yeah. And so you could say it doesn't make sense, right? Because this is something that really is medically necessary, and yet it isn't something that Medicare typically provides for. So what you'll find is that a lot of Medicare supplement companies will have little discounts that you can get with different hearing vendors, dental and vision. And then, of course, Medicare Advantage plans, which we'll talk about in a future episode. Some of them will offer some coverage for things like that, but routine dental, vision, and hearing. And then a big one is long-term care. So I can't tell you how many people contact us and want to know, what does mom's Medicare coverage pay now that she's in assisted living? And the answer is her Medicare coverage will still take care of her doctor visits, inpatient and outpatient, but it doesn't pay for the rent for her to stay in an assisted living or nursing home. So even if you had someone coming into your home that was doing custodial care in a long-term nature, those are things that Medicare pays either very little or nothing on. So you do still have to have a plan in place for your future. Someday, if you're not able to do the activities of daily living on your own and you need to stay somewhere like that, Medicare does not pay for that.
Medicare does not pay for long-term care. Within that type of environment, I think of long-term care, they're not going to pay for the rent, the food, the custodial care. What about the nurses and the drugs that work in a facility like that?
So a lot of times the facility will know what Medicare plans you have in place. They may even suggest certain plans. So for example, a Part D drug plan, when they prescribe a medication, you may have a doctor that comes around to visit you at your assisted living facility. He's going to prescribe medications, and those are still going to run through your Part D drug plan. But it might be a thing where one plan is going to be better because the mail order pharmacy that delivers to that assisted living center is through XYZ drug plan. So there's some coordinating that usually needs to be done there by a family member. And also, if you have original Medicare and a Medicare supplement, that doctor is usually going to be able to treat you just fine. But if you have a Medicare Advantage plan where there are networks, if that doctor isn't in the network, now we're facing a plan change. So there's a lot of big decisions that surround the whole entry into assisted living and long-term care. And we could get off on a whole nother topic about that. But again, it's just something you need to be aware of that you need to prepare for financially.
Yeah. And back in February, I believe, we did an entire month on long-term care. So you can go check out those episodes.
Awesome.
With Steve Kane, who is awesome at talking about the subject, very much like you are, Danielle. One question back on Part D real quick, because you mentioned it. Are you able to switch, like if I have this company one year, I can switch to company 2 the next year or in between.
You can, and it's very important that you review your coverage every year, because something about Part D drug plans is, since Medicare changes the deductibles and limits for all those 4 stages that we talked about, the Medicare drug plans then change their benefits within those plans every year. So a plan that you're on that you may really like and is paying just the way you need it to in 2020 may pay very differently in 2021. So every year in September, your Part D drug plan will send you an annual notice of change letter. You need to look at it carefully. What is your premium changing to? Is it going up or down? Is the deductible changing? What about the copays on your most expensive medications? Are those getting higher? And most importantly, is that Part D company dropping next year one of the most important medications that you take? Often we see these Part D companies will drop the brand name drug as soon as a generic comes out. So that's something you also have to look at. And so very important in September to review that annual notice of change. Look to see if you're okay with how that plan will be next year, and use your mymedicare.gov portal to run a search on all the drug plans, because you may love the drug plan that you have even with the changes, but you might find when you run an analysis that another drug plan in your area could save you $500 a year. And so you would then make that change during the annual election period in the fall, which happens every year from October 15th to December 7th. That's when you can make a change to your drug plan.
Okay, so that's really important. I think of decisions like that as certain decisions degrade at different rates. So that one's going to degrade over a 12-month period that you have to renew the decision to try to optimize. So let's talk briefly about anything else that it doesn't cover. We have the deductibles, we have the copays, we have the dirty donut in Part D, we have long-term care, dental and vision. When I was thinking about vision, Danielle, I was like, okay, you pay for my glasses or you pay for me in the hospital when I hit a pole. Which one you want to choose? I think you should pay for my glasses. But
yes.
Anything else that we need to know about there?
There are some other little random things. So for example, Medicare doesn't cover routine foot care unless you happen to have a health condition that requires it, like diabetic neuropathy. So people who go to a podiatrist a lot of just for regular foot care because they want to, may find that they get on Medicare and that's not covered. And then there's some really obvious ones, right? Like cosmetic surgery, they're not going to pay for your Botox. They might pay for it if you're getting it for migraines, but they're not going to pay for, us ladies like to keep our frown lines in check. Those type of things are typically going to be out of pocket.
Hey, us men like that too.
Okay, well that's good to know.
I like my frown lines. I'm not worried about it, but
well, just know that Medicare won't pay for that if you ever change your mind on that.
Okay. I just thought of something. Does this work like an HMO, or say if I want to go to a podiatrist, do I have to get a referral?
Not if you stick with original Medicare. You can see any Medicare provider, which there are over 1 million of them in the United States. So original Medicare A and B, no primary care doctor to select, no referrals. You can get up and go see your own doctor as long as he takes Medicare. Medicare Advantage plans, which we'll get into in a future episode, very different. And those do have a network, which you would need to check before you could see a physician or maybe get a referral. If you wake up with foot pain or you wake up with a blemish and you want to see a dermatologist on original Medicare, you can just find one in the online search and go. With an Advantage plan, you need to stay in the network.
Okay. Great. Well, so next week, we're going to talk about Medigap, Medicare Advantage to plug the holes of the leaky bucket financially. And then we'll continue on this journey. Thanks, Danielle.
You're welcome. I enjoyed being here. Thank you.
Well, welcome to the question and answer session of the show, where we answer your questions about how do you rock retirement. And if you have a question that you'd like to submit, we'll try to answer it on the air. And you can do that at rogerwhitney.com/askroger. And I'm doing the solo today, but we're going to have more guests on the show. And believe me, I think Nicole will be coming back soon, which is exciting. But for now, let's get to Hal's question on life insurance. And he wants to know, how do you fund a special needs trust? He says they have a son with special needs, and they want to know how best to fund the trust. And he also throws in there that he has a term life insurance contract that expires in about 2 years that they really don't have a need for, that he believes anyway. And he wants to know, should he cancel that or maybe convert that to help fund the special needs trust? So it's a good question, Hal. And a special needs trust is a trust that you set up to be able to take care of someone who may not be able to take care of themselves when you passed. And life insurance can be a really great way to fund a special needs trust. Now, in terms of your term insurance policy, that's probably not going to be adequate because it only has 2 years left in the fixed premium. And then after that, it's going to adjust to your age. So it's likely going to be way too expensive to continue to carry. So typical ways that you would fund a special needs trust are, in terms of life insurance, is using something called a second to die policy. So assuming that you're married, Hal, you can do a second to die policy, which is usually a universal life or whole life type of policy that will pay out the death benefit once both you and your wife pass. And by combining it together as a second to die policy, it can be a little less expensive. And these type of policies you can structure so you can fund them with one payment, or you can pay over 10 years, or almost any term that you want. And that is used to fund with the death benefit a special needs trust. That's the general way that I've seen this funded in the past. Another way would be to put in family home or real estate that could be used either for income or to liquidate within the special needs trust to work on providing for the children. But I think that term life insurance policy you have is probably not going to be a great solution, although you may want to keep it at least for the next 2 years because you'll likely never get that kind of premium again. So hopefully that helps answer your question. Now, our second question comes from Frank, and this is on buckets. And he says, one of the strategies while in retirement is a bucket system where one sells stocks to refill the income bucket. And he says, the idea being to sell gains and holding off on selling when the markets are down or when your pot of money is down. And what he's trying to figure out is, what is the benchmark for when you actually have a gain? Is it the market value on the day that you retired? Is it the share price one uses forever? These accounts have accumulated for over 40 years, the up and downs. So what's the benchmark you use to decide whether there's a gain or loss there in order to sell to refill your buckets? Well, Frank, that's a great question. It is sort of mind twisting, as you said. And to be honest with you, I'm not a fan of simply selling winners or stocks to refill buckets. So I'll explain that in a minute. In terms of a benchmark, I think this is not a place you would actually use a benchmark in the way that you're thinking. And then maybe that's why it's so time or mind twisting, because it doesn't really matter. What we like to do, or the way we think about it, is each year you're going to rerun your confidence levels of the cash flow or the life you want to live and the spending model that you have. You're going to determine your needs, how much you need to cover for, say, the next 2 years of needs, wants, and wishes. And then you're going to determine how much you need to refill your cash reserve based on those spending needs. And if you're going to pull from long-term investments, let's say you have to refill your buckets because they're getting lower than you're comfortable with in terms of your bucket strategy, it's not so much about selling the winners only when they're up, although you can do that opportunistically just to make hay while the sun shines. Really what you're going to do is pull from your longer-term investments. And you can refer back to an episode I did in January on the pie cake structure. So when we are refilling buckets, we're not just simply looking to sell winners. What we do is we look at the allocation for our long-term assets. And in rebalancing that allocation, we look for efficient ways to skim off the money we need in order to refill the buckets. So it's not just simply selling the winners when there's winners, because that can really get you into, well, a mind-twisting exercise of what do you do when everything's a loser, which there are periods of time when it feels like everything's a loser. How do you refill the buckets then? I recall back in the 2007, 2008 period of time when I was walking this journey with clients. And the way that we did it was, because we had buckets in place, we'll use your terminology, we did allow those to dwindle down more than normal. But we coupled that with continually rebalancing the portfolio as well as dialing down wants and wishes. And I think that's actually an important element when you're thinking of bucket strategies in general. Is in theory, it may make sense that in bad times, you just dwindle down your buckets and wait it out. That's like sitting in a bunker, just sort of waiting for the storm to pass. And indeed, we do have to do some of that sometimes. But that doesn't feel very proactive. And when things are stressful, it's important that we have actions that we can take. And one action you can take to help mitigate the dwindling of those buckets during hard times is making different choices. Rather than go to Europe, I go to Colorado. Rather than have filet mignon, I buy a sirloin. Those seem small, and some of them can be pretty big. But I think people, at least in my experience that I walk with, they want to be part of the solution and make active decisions in terms of lifestyle choices when times are hard. And I think that's important, not to steal that from somebody or steal it from yourself and just say you're going to dwindle these buckets. So Frank, I would say don't use a benchmark of gains or losses. Each year you're going to have to reevaluate this and start to fill forward the cash flow needs that you're going to have regardless of what markets are doing. And I think that's a much better position to be in. So hopefully that clarifies it so you can untwist your mind a little bit. So our last question this week comes from Jeff on his mother's estate. He says his mother is 84, in an assisted living, but doing really well. He has power of attorney over everything, and she has all her directives in place. And she has a very simple will from the 1980s. Wow, that's a long time ago. But she has no debt and about $175,000 in assets to pay for assisted living. And what Jeff wants to know is, what should I have in place to more easily settle her estate? Which is a good question, because we think about probate, and depending on what state you live in, probate can be very expensive and very time consuming. So Jeff, a couple observations here. One is, if the $175,000 in assets is all money or financial assets of some sort, one thing you could do is change it to what's called a transfer on death account, which is essentially putting a beneficiary on, say, a checking account or an investment account. So when she does pass, whoever the beneficiary is, and let's assume it's you in this case, the money would automatically transfer by the documentation directly to you, so it wouldn't have to go through probate. So one thing is, you could use a transfer on death account designation. Every state is a little bit different on that, but you can check that. If you have non-financial assets, say a home or something like that, and you wanted to bypass the probate process, you could put everything into a living trust, which would bypass the probate and then would be distributed based on the terms of the trust. Now, even something like that, if you decide to go that route, now you have to change the deed, you have to change titling. The administrative hassle just to go through that might be not just about the same as going through probate. I don't know. And then another thing to consider is, if there are no assets to be distributed, probate isn't necessary. In fact, each state has a threshold on when something actually has to go through probate. Some states, if it's $50,000 or less, they don't want you to go through probate. They make a simplified process. But I think either a transfer on death designation would be a good idea. 2, look at the probate in your state, because it may be fairly simple. In Texas, where I live, probate's actually very inexpensive and not that complicated, so it may not be an issue. And then lastly, it may be below the threshold anyway, so it might not be an issue. So hopefully that gives you some guidance, Jess. With that, let's get on to our SMART Sprint.
On your marks, get set.
And we're off to set a little baby step we can take in 7 days to work towards rocking retirement. All right, in the next 7 days, I want you to ponder on, what does being true to yourself really mean? That can be a hard question. I'm not going to pose and say I have that figured out. Everything I do at the show and the club and everything else is my current expression of being true to myself, but it's a hard question. So start to ponder that, because as you get closer to retirement, we're going to make sure we minimize that number one regret at the end. Well, this time next week, I will be back from Colorado and into a normal groove again, and I'll have some observations of this 5-week journey of living someplace else. But I thank you for listening to the show. I'm so glad that you are here with me, and I hope you find it helpful. Be well. Hey, it's time for that all-important disclaimer. We so appreciate you listening to the show and love your questions and love the teaching that we're able to provide here. And actually, it helps us too. But remember, you're not our clients.
Not love it if you took advice from us on the show.
We would not love it if you took advice from us on the show. Realize this is helpful in education. Talk to your legal advisor, your tax advisor, or your financial advisor before you make any decisions.
We appreciate you joining us today for this episode of Retirement Answer Man. Be sure to visit rogerwhitney.com/answers to access the Retirement Answer Library with over 30 checklists to help you make the most of the only life you have. Remember, you have more power than you realize to create an amazing life starting today with Retirement Answer Man. The opinions voiced in this material are for general information only and are not intended to provide specific advice or recommendations for any individual. All performance referenced is historical and no guarantee of future results. All indices are unmanaged and may not be invested into directly. Have a wonderful day.